Hello and welcome to Derm School. Today we are going to look at Lichen planus and Pityriasis rosea. First, we shall look at Lichen planus. This is the outline of what we will be discussing today. Introduction, etiology, clinical manifestation, followed by treatment. Lichen planus is an acute or chronic inflammatory dermatosis. It can affect your skin and/or the mucous membranes, and it is very famous for the 6 P's of Lichen planus. There is a predilection for the flexural aspects of your arms and legs. In the mouth, there are milky white reticulated papules, and this may become erosive and ulcerate. There's also often pruritus, and with mouth lesions, the patients can experience pain. Treatment is often with glucocorticoids, whether systemic or topical, as well as cyclosporin. In terms of etiology, Lichen planus can be idiopathic and possibly related to cell-mediated immunity. Other etiologic agents may include drugs, metals such as gold or mercury, infections, namely hepatitis C, as well as associated with some HLA-associated genetic susceptibility. These are the famous 6 P's of Lichen planus for the skin lesions. Firstly, plana, which means flat-topped, papule, plaque, which are purple, polygonal, and pruritic. So you can observe all these characteristics in the photograph. Other features of Lichen planus. The lesions are often grouped, they may be annular or even disseminated when generalized. In dark skin, they can leave post-inflammatory hyperpigmentation. Lichen planus may also present on the lips, and there is often Kuttner phenomenon in which you see a linear arrangement after trauma, as illustrated in the photograph. Sites of predilection of Lichen planus. At the wrists, namely the flexor aspects, lumbar region, on the shins, which are often thicker plaques or hyperkeratotic, scalp, glans penis, as well as the mouth. The following are variants of Lichen planus: hypertrophic, atrophic, follicular, vesicular, pigmentosus, actinicus, which means over the sun-exposed sites, as well as ulcerative. Involvement of the mucous membranes can present with reticular appearance, and it can eventually become erosive or ulcerative. This is Wickham striae. These are palest white streaks in a reticulate pattern, often seen on the mucous membranes. And you can see here there is reticulated and eroded Lichen planus on the lower lip. Other areas of involvement include the genitalia, the scalp, in which the patients can present with lichen planopilaris, which is follicular, frontal fibrosing alopecia, as well as pseudopelade of Brock, and these tend to be scarring forms of alopecia. On the nails, there's destruction of the nail fold and nail bed, pterygium, as well as longitudinal splintering. For local treatment, you can consider the use of potent topical corticosteroids, topical calcineurin inhibitors such as tacrolimus or pimecrolimus, topical retinoids, intralesional steroids, and cyclosporin or tacrolimus mouthwash for oral Lichen planus. For systemic treatment, this is indicated for widespread or severe local disease. Options include steroids, cyclosporin, acitretin, hydroxychloroquine, methotrexate, azathioprine, mycophenolate mofetil, as well as phototherapy. The second topic that we will discuss today is Pityriasis rosea. This is the outline of the lecture: introduction, etiology, clinical manifestation, cause, as well as treatment. What is Pityriasis rosea? It is an acute exanthematous eruption with distinctive morphology and a characteristic self-limited cause. It is related to the reactivation of human herpes virus 7 or 6. It is characterized by the appearance of a harrow patch at first, and this is an oval, slightly raised plaque or patch measuring approximately 2 to 5 centimeter. It is often salmon red in color with fine collarette scales at the periphery, and the harrow patch may also be multiple. 1 to 2 weeks later, the patient develops an exanthum, which is a generalized secondary eruption of fine scaling papules and plaques with a marginal collarette, and the color is often dull pink or tawny. These lesions are oval and scattered, often in a Christmas tree pattern, as you can see in the picture, which means along the long axis following the lines of cleavage. Sites of distribution include the trunk, as well as the proximal arms and legs, and very rarely on the face. This spontaneously remits in about 6 to 12 weeks or less, and recurrences are uncommon. Management: oral antihistamines for itch, topical glucocorticoids, the use of oral erythromycin or oral acyclovir, and in some cases, you can consider phototherapy. So that's all for today, and we'll see you again in the next installment of Derm School. Thank you and have a nice day.